Kwashiorkor is a form of severe protein-neuroenergy malnutrition characterized by edema, irritability, anorexia, ulcerating dermatoses, and an enlarged liver with fatty infiltrates. Sufficient calorie intake, but with insufficient protein consumption, distinguishes it from marasmus. Kwashiorkor cases occur in areas of famine or poor food supply. Cases in the developed world are rare. Jamaican pediatrician Cicely Williams introduced the name into the medical community in her 1935 Lancet article. The name is derived from the Ga language of coastal Ghana, translated as the sickness the baby gets when the new baby comes, and reflecting the development of the condition in an older child who has been weaned from the breast when a younger sibling comes. Breast milk contains proteins and amino acids vital to a child's growth. In at-risk populations, Kwashiorkor may develop after a mother weans her child from breast milk, replacing it with a diet high in carbohydrates, especially starches, but deficient in protein. Signs and symptoms. The defining sign of Kwashiorkor in a malnourished child is pitting edema. Other signs include a distended abdomen, an enlarged liver with fatty infiltrates, thinning hair, loss of teeth, skin depigmentation and dermatitis. Children with Kwashiorkor often develop irritability and anorexia. Victims of Kwashiorkor fail to produce antibodies following vaccination against diseases, including diphtheria and typhoid. Generally, the disease can be treated by adding protein to the diet. However, it can have a long-term impact on a child's physical and mental development, and in severe cases may lead to death. In dry climates, marasmus is the more frequent disease associated with malnutrition. Another malnutrition syndrome includes cachexia, although it is often caused by underlying illnesses. These are important considerations in the treatment of the patients. Causes. Kwashiorkor is a severe form of malnutrition, caused by a deficiency in dietary protein. The extreme lack of protein causes an osmotic imbalance in the gastrointestinal system, causing swelling of the gut diagnosed as an edema or retention of water. Extreme fluid retention observed in individuals suffering from Kwashiorkor is a direct result of irregularities of the lymphatic system and capillary exchange. The lymphatic system serves three major purposes: fluid recovery, immunity, and lipid absorption. Victims of Kwashiorkor commonly exhibit a reduced ability to recover fluids, immune system failure, and low lipid absorption, all of which result from severe undernourishment. Fluid recovery in the lymphatic system is accomplished by reabsorption of water and proteins which are returned to the blood. Compromised fluid recovery results in the characteristic belly distension observed in highly malnourished children. Capillary exchange between the lymphatic system and the bloodstream is stunted due to the inability of the body to effectively overcome the hydrostatic pressure gradient. Proteins, mainly albumin, are responsible for creating the colloid osmotic pressure observed in the blood and tissue fluids. The difference in the COP of the blood and tissue is called the oncotic pressure. The oncotic pressure is in direct opposition with the hydrostatic pressure and tends to draw water back into the capillary by osmosis. However, due to the lack of proteins, no substantial pressure gradient can be established to draw fluids from the tissue back into the bloodstream. This results in the pooling of fluids, causing the swelling and distension of the abdomen. The low protein intake leads to some specific signs: edema of the hands and feet, irritability, anorexia, a desquamative rash, hair discoloration, and a large fatty liver. The typical swollen abdomen is due to two causes: ascites because of hypoalbuminemia, and enlarged fatty liver. Ignorance of nutrition can be a cause. Latham, director of the program in international nutrition at Cornell University, along with Keith Rosenberg, cited a case where parents who fed their child cassava failed to recognize malnutrition because of the edema caused by the syndrome and insisted the child was well nourished despite the lack of dietary protein. Protein should be supplied only for anabolic purposes. The catabolic needs should be satisfied with carbohydrate and fat. Protein catabolism involves the urea cycle, which is located in the liver and can easily overwhelm the capacity of an already damaged organ. The resulting liver failure can be fatal. This means in patients suffering from Kwashiorkor, protein must be introduced back into the diet gradually. Clinical solutions include weaning the affected with milk products and increasing the intake of proteinaceous material to daily recommended amounts. See also, anemia, asides, emaciation, starvation, notes. References, Mortality in a Rural Zulu Community, external links, media related to Kwashiorkor at Wikimedia Commons.